Hello, welcome to the one of the last classes, and I have the privilege today of introducing Dr. Herb Harmon, who
Hello.
is a medical, he's a psychiatrist and a medical doctor with CEP America. He and I work together there, and he's one of the most brilliant and talented physicians, as well as very caring and very willing to embrace technology. So I will let Dr. Harmon also has experience as he's a veteran, and he is has a wide range of experiences. So I thought I'd introduce him today to give you all a realistic view of what it's like to be a physician on the front lines using telemedicine. So Dr. Harmon, would you go ahead and if you wouldn't mind introducing yourself again in your own words, and then talking a little bit about telepsychiatry and how you sort of how it works for you and your thoughts about it.
Sure. Thanks, Andrea. Yeah, I'm Dr. Herb Harmon. She was mentioning, I'm a physician went to medical school at the University of Virginia in Charlottesville, and then did psychiatric residency training at UPMC Western Psychiatric in Pittsburgh, Pennsylvania. After that, I did 4 years active duty military as a psychiatrist with the Air Force and one deployment. Spent a number of years working for different organizations, both near Philadelphia, Pennsylvania, and then for more years in Charlotte, North Carolina, working in emergency rooms, mostly psychiatric emergency rooms, and also doing consultations in emergency rooms. The last 5 years, I've done a lot of clinic work with patients, and then still kept my foot in the door with hospitals, including OHSU up in Portland at the new Behavioral Health Unity. For more than a year now, I've been working with CEP America, and I've been the director for telepsychiatry. We've been working with the technology platform and with hospital systems to contract, and partners are then able to go into hospitals, most often the emergency room, and see patients who have an emergency room physician who has requested an emergency consultation, so they can get some help figuring out what to do next with the patient that is sitting there in their ER. As you can imagine, every specialty is not always available at all hours at all hospitals in physical presence. Scaling that is possible with technology, and the challenge, as I'm sure you've covered in your class, is licensing, logistics, finances, the emerging software systems, and firewalls, and all this great stuff you've been learning about. So those have been my obstacles, and we've overcome a lot of them, but not all of them. I don't think we'll ever fully be overcoming all of it, because it's a moving target. Everything's changing all the time. So very dynamic.
So, Dr. Harmon, when you are working in telepsychiatry, can you tell us a little bit about how you see telepsychiatry being used in its highest value? In other words, what's the sort of highest and best use of it? And also, your thoughts around the safety of telemedicine and its use in the telepsychiatry field.
Sure. I'd say easily the best use is just the on-demand service, right? So if you live in a town and there's a clinic, you can physically go into the clinic. You should probably do that, right? People appreciate getting to have you there, and you can offer, when you're physically there, it's a little easier to offer some leadership and management for everybody. Just even just to get to know your receptionist and make sure that that person knows some of the basic things about trauma-informed care, and how to meet a patient who's suffering, and conceptualize their suffering in a way that allows you to have compassion. If you're physically there, you can do all kinds of things that go well beyond the individual encounter. So telemedicine doesn't add too much in that way for that kind of scenario. However, if you can imagine there being 20 hospitals that each have one patient they want help with a day. So if each of those 20 hospitals had to hire a physician, not only is it not realistic to find that many physicians, it's also not possible to find enough money to pay all of them to be there all the time. It doesn't work. So that just from a common sense way of thinking that's just not, it's not going to work. And if you go to a small community hospital, you're not going to find, for instance, a psychiatrist, a neurosurgeon, and an orthopedic surgeon just sitting there at 2 a.m, watching TV, waiting for the next patient to come in. Those patients are going to get probably transferred. So with psychiatry specifically, we can make it possible for them to not necessarily be transferred, because most of what we do is through communication, and the technology allows us to do that. If the physical exam is done by the nurses and the doctors there, and they're able to tell us with confidence that we don't need to do a physical exam, we can just focus on the interview, which is really what we're doing probably more than 90% of the time anyway. So they screen out those folks that we would need to do a physical exam on. Maybe they wouldn't call us for those, but most of them they can. And by seeing somebody where they are at, when they need us, we deliver the best care. You can imagine, if someone had a heart attack and they put him in a back room, said, well, we don't have a cardiologist here, so why don't you sit back there, and hopefully it's not actually a heart attack. And whenever a cardiologist comes around, we'll have that dealt with. With psychiatry, that happens a lot for patients with psychiatric symptoms. They're just kind of put in a back room, or medicated heavily, or strapped down. And it creates a lot of bad outcomes. It hurts patients. It hurts morale for the staff. Nobody wants it to be that way. So it's the on-demand access that is the first way it works best. And then the other way that I think is you'll see telemedicine, and specifically telepsychiatry, really help people, is with complex care management and case management. And then I don't think we're doing too much of that yet, and everyone's talking about it, but trying to figure out how to fund it will be key. But for patients who have complex problems, they have heart disease, they have cancer, they have diabetes, they've had a stroke, they have depression, they have a psychotic illness, whatever, you might have a hospitalist, an internist who's trying to help them. And if they could flip a switch and create a conference call with all the specialists who have been able to review that person's record and or interview the patient, 5 minutes with everybody in the same room at the same time, could really accelerate what you're able to do for them. And it's not really possible in most places that aren't, like, for instance, the Mayo Clinic or the Cleveland Clinic. There are a few places in the country where you can get that kind of care, but almost all of it it's taken decades to build, and it's subsidized by some sort of funding that most community hospitals, of course, do not have and are not going to have.
Got it.
So part of...
Interrupt you for a second. So to the classroom, I just want you to know, this is when Dr. Harmon is talking about the complex care management and capitation. He's basically talking about the population health concepts that you're learning in some of your other classes. In other words, in the sense of, you've got a small group of patients that are using medical services intensely, and the organization that's responsible for them is paid a per member per month fee in order to keep them healthy. So the idea is to get them care as quickly as possible, and to make sure that they go to the right level of care, to line acuity with care location. So I'm sorry to cut you off, Dr. Harmon. I just wanted to make sure the class understood the perspective you were coming from. So keep going.
Sure, right, and that's very important. If in systems where you're simply paid if you see person X but not person Y, you can imagine it's only a matter of time before the system always makes sure that person X is the one in front of you. Whether we like it or not, that's how humans behave. So if you're given a big sum of money for a large number of people and say, do the best you can, and then there's some sort of accountability, and there's some sort of metrics you're following, and you have good leadership, you can do a tremendous amount of good work if the physicians then are able to make decisions based on what really needs to happen for the individual patient, as opposed to checking a whole bunch of boxes that don't make any sense. So telemedicine should allow us to take that next step if healthcare goes more to value-based reimbursements and capitated systems for certain populations. It's not always going to be the case for everybody. There are places where fee-for-service is fine, but telemedicine, I think, will really make it possible to create value-based outcomes that are improved if and when that becomes more of a reality for us.
Great, thank you. One last question is, and maybe you've already answered it, but what do you see as the future of telemedicine in the psychiatric field? I mean, kind of blue sky it. Do you see the use of artificial intelligence? Do you see the use of holograms? I mean, what is there anything, just from a purely like, this is where I see it going, or it may be something more conservative than that, but do you have some thoughts on the future of telemedicine specifically in the field of psychiatry?
Yeah, I mean, in terms of if sky's the limit, sure. I mean, with artificial intelligence, it's really hard to say. I mean, there's some stuff out there showing that linguists who have worked at software that detects how your voice, that it might be that a software program, just by listening to someone speak, can do a better job at uncovering the depths of depression for somebody than we're doing in some of our interviews, or certainly better than we're doing capturing by a checklist of somebody a technician coming in. Are you not sleeping? Check. Or going down. Check. Like these measures are they're not meaningless, but they're going to become almost meaningless once we get our act together and really figure out what data points we should be capturing. So I do think that another frontier for telemedicine and telepsychiatry is using advanced providers more effectively and more efficiently. Multiple teams of nurses, social workers, and nurse practitioners working together under the supervision of psychiatry can be way more effective and way more efficient than everybody waiting to talk to me, right? So this, and in most other industries, that's how it works. You're building a skyscraper, you have a chief engineer, and that engineer does not turn every bolt. It's just ridiculous, right? So we have to be more mindful of how we're doing things and learn from other kinds of industry how to do it better. So I would say that's how I see it. And I think you asked, and I failed to answer about whether or not I think it's safe. I absolutely think it's safe as long as to offer medicine to offer psychiatry services through telemedicine. But I think that also requires a degree of supervision and humility, right? So for instance, when you have some constraints on what you claim you can do up front and you honor that, I think it's good. So for instance, places where we are seeing patients infrequently, we try not to write orders directly. We try to talk to the emergency doctor directly and say, hey, this is what I think is going on. This is what I suggest. And we leave it to them to write the order because we're not living in their space, And so I think when you set some parameters like that and you still are relying on some people that are physically present to put the final pieces together, it can be very safe. If you get too cavalier and think that in a 5-minute interview you can write 100 orders on somebody for a complex problem, I think that's when you might find yourself in trouble.
So just to recap, two of the things that you said, which are really interesting, I want the students to take note of. One is that there is innovation that occurs not just with software and hardware, but innovation in operations, innovation in collaboration. And I think that for all the students that are taking these classes, you are all going to be in a position to potentially lead some of those innovations. You don't have to be a software developer or a technologist in order to be innovative in healthcare, even in the telemedicine space. So, and to Dr. Harmon's point, collaboration, teamwork, and ensuring that all parties take into account the full picture, I think, is one of the key components of good healthcare, good management, regardless if there's technology involved. So, any final words, Dr. Harmon?
I don't think I have anything else to add. I'm excited to know that there's a class like this. That's really great. Things have changed a lot. Not too long ago, there was just like journal articles about things that were happening in Australia and across the military, and very little about telemedicine. And now there's huge conferences, and most people know about it or have seen a provider or talked to a nurse through some sort of platform like this. So it's fun. I enjoy being a part of it, and thanks for including me.
Well, thank you very much for today, and really appreciate you taking time out of your really busy schedule, which I know you have. So thank you so much. Have a good day.